we should plan to start the meeting because at least this is the first meeting. We should stick to the time. So this meeting is basically there are two most important points here. One is to set the tone and talk about what we will be doing, and second is the fact that we should be knowing each other. So I will, I will start with I will start with myself. I am Dr. Jiten Jethani, and I am the course instructor for this. And I welcome you all in the course. And then I would like each of you to introduce yourself so that we can know each other in the group and we can have healthy discussions regarding myopia, talking about myopia, what we will be doing in future. So I think Dr. Snehal is there. I can see her on video. Dr. Uday has
Hello,
come back.
I'm Dr. Snehal
She
Thackeray.
was there. Yes, please. Yes, ma'am.
So I'm Dr. Snehal Thackeray. I am practicing in Aurangabad. I'm a professor in MGM Medical College here. Thank you.
Wonderful. Thank you, ma'am, for joining the course.
Yeah, I'm really looking forward to it. Thank you.
Hello, I am Dr. Shreyas. Hello.
Wonderful. Yes, sir. We can hear you.
Okay. Hello, I am Dr. Shreyas. I just completed my MS and I did my IOL fellowship from Shankaraya Hospital, Indore. And now I joined the course because I want to learn more regarding myopia. Thank you.
Thank you. Thank you so much, sir. Thank you for joining the course.
I'm Dr. Chandrakishore from Gondia. I'm working as a ophthalmic surgeon here in a private hospital. So I also looking forward for myopia control program because most of the patients we are just treating, but new advancement I think we'll get in these lectures. So that's why we have joined.
Wonderful. Welcome, sir. I personally know Dr. Snehal. I know Dr. Uday also. And Dr. Uday, you can introduce or Drishti can introduce.
Yeah, hello. So, am I audible?
Yes, yes, ma'am.
So, I'm Drishti Modi. I'm an optometrist and I'm from Ahmedabad. So, currently I'm practicing specialty contact lenses in Ahmedabad since 4 years. And I completed my fellowship, 2 years long-term fellowship for LV Prasad. So,
Wonderful.
so we met, several of time we met in IMARC.
Yes, we have met in IMARC. IMARC is in November. We are looking forward to it.
Yes, and we also have private.
Good to have you with us, Drishti.
Thank you, sir. And we also have our private practice in Ahmedabad. My father is also an optometrist. So we are also practicing myopia control. So I joined this course for more upgradation and I want to learn from you, sir.
Thank you so much. Thank you.
Okay.
I hope we can live it to the expectation.
Definitely, sir. Yeah. Thanks.
Hello, good evening. Myself, I am Dr. Uday Naik. I am from Nanded. Hello. Am I audible?
Yes, sir.
I'm Dr. Uday Naik. I am from Nanded, Maharashtra. I am practicing pediatric ophthalmology since 2008. And as we all know, there is a pandemic of myopia, which is progressing rapidly. And we see many complications with high myopes and all. So it's always better that we should contain it. So this is my motto to join this myopia progression class.
Wonderful. I think Dr. Nitin had informed that he won't be there. Dr. Nitin is also a good friend. He also is part of the group. And I think I welcome you all. Thank you for joining the course. And the success of the course completely depends on what transpires during this particular 3 to 4 months, the journey that we all will take together. Most importantly, I think in the coming years, we would definitely realize we already know by wonderful articles. I had shared it on the group also. And normally we try to share those articles which are relevant. We try to initiate the discussions so that more and more information passes on. If you go through the article by Gisela and Pawan Varkicharla from LVP, you would realize that they have done some good work on the fact that myopia. What they have done is they have transposed or rather extrapolated the data, and they have also tried to show that almost 40 to 45% of children or of the population in India would eventually become myope. And once they become myope, what happens is that progression is almost there in 80% of the children. So, so whoever patient progresses, it is not only, it not only adds to the whole burden of myopia. These patients do come in our practice, and we have to, not only deal with these patients, we also have to see what is happening. Because typically, like way back in 2015 or 16, when myopes that, we would just tell them that nothing much can be done. And over a period of time, we do realize that, see, if you go back a couple of years back, there was no such device which can do auto refraction and do optical biometry. There are modern optical biometers available which will be doing auto ref also, and it will be doing biometry also. So these are devices which are typically for myopia. So that, see, you have to see the market. If market is moving towards myopia, if there are more devices which are coming up, it means that this particular branch is going to progress, and we have to understand it. See, we don't have to do a separate fellowship to learn myopia. We all know myopia. We have been doing this. We all know how to do cycloplegic refraction. We know how to prescribe glasses. We know how to do accommodative lag. We know all these things. We just have to make an effort to collaborate everything. We have to understand that if we want to start atropine, or if we want to think of starting glasses, or if we want a particular treatment protocol, we have to first know who is a progressor. That is number one. And whether he is progressing or not, number two. And number three is which are the data points which we have to collect. Once we have those data points, then it is very easy for us to understand that this particular patient is progressing, he will progress. Now, beyond this discussion, we also have a separate small subset of population who are pre-myopes. Now, pre-myopes also, gradually they will become more and more important, because what happens is that pre-myopes are the actual patients where you can actually prevent myopia. A lot of times, when I started practicing myopia, a lot of my friends would say, or rather some of the patients also would say that, Doctor Sahab, what is the difference? I will be wearing -3. I will start wearing -4. I will start wearing -5. What is the big deal about it? After 18 years of age, we will operate and finish off the glasses. In the coming lectures, I will be, showing you some of the data, some of there's a very good article which was published in, I think that was in Review of Myopia Management, where they showed that with each diopter of progression, the risk of myopic maculopathy, the risk of retinal detachment, the risk of glaucoma, all these things, they will come at a very late phase. At this point of time, we are looking at a kid who is 6 years, a kid who is 14 years, and cut to a point which is 35 years after this point. We may not be a care provider at that point of time. The patient may have moved. We may have, we may have stopped our practice after 30, 35 years, but these patients would definitely suffer from myopic complications. That is part one. So this is from the clinical point, that we are trying to prevent disease process. Now I come to the business point. Once there are more and more myopes means there will be more and more demand of treatment from these myopic patients. If at this point of time we don't understand, or we don't accept this, that myopia is a separate branch, or rather we should do something for this, in gradual course of time, what will happen is that we won't get a scientific thought process about it. Patient would be treated here and there. We won't realize what is happening. The whole interest, the whole research work that is going on right now in myopia would cease to exist, because there are no patients to take that. So at this point of time, it is very, very important to understand that even if we have a busy cataract practice, we do have time to at least train our optometrist or train ourselves for a couple of data points. We just want to have few data points in all the patients. And it is all about setting up the system. It is very similar to glaucoma. If you have a system, that, all glaucoma patients, or rather all patients above 40, IOP will be checked, Pachymetry checked, fundus photo will be taken. Just similar to a cataract surgery, before cataract surgery, you will be checking the blood pressure, you will be checking the blood sugar, you will be checking few things. Similar to that, if a myopia patient comes, we have to check these things. And when he comes back for follow-up, we have to check these things. And then if there is a progression, then you have to come in between and tell the patient that, there is a progression and these things have to be done. It becomes very easy, to join the journey at the beginning. Once the journey starts, after 6-7 years, what happens is there are too many things in myopia, and then what happens is we feel ki, chodo, this is a super specialization, this is a completely different ball game, we won't be able to handle it. So it is a good idea to join the whole process in the beginning itself, so that we can have a comprehensive understanding. And gradually, see, myopia is a very dynamic field at this point of time. Why it is dynamic? The primary reason why it is a very, very dynamic field at this point of time is because a lot of questions are unanswered. There are hypothetical situations or hypothetical answers. We truly don't know that, this particular thing, what it will do in very long term. So there will be evidence which will keep on coming in coming years. We will be knowing that this particular thing we could have done this better. Like if you go and read the Atlas study, which got published last year, where they tried to follow up the patients who were given low dose atropine, low concentration atropine in 2006 to 2010. Now what they found, so they could get only 60% of the children who became adults were followed up. So their data was not complete. But the second part of that was that, all these children who came to follow up, they realized when they compared them between control and the patients who were not in control, between these two patients, there was not a significant difference. So what they understood was, one thing, for a person who does not believe in atropine, what he will say is that atropine was useless. For a person who understands the myopia progression or myopia control, would say that, we could have done treatment for a longer period of time, which means that atropine should not only be used for 2 years. You can use it for at least 3 or 3.5 years. And then if you want to stop, keep the patient in your loop. You have to keep the patient in follow-up. And if you see the patient is progressing, you have to tell the patient that he has to restart atropine. I think Mansi has joined. We can ask her to give introduction and we can carry on with the discussion. Mansi, are you there?
Hello. Am I
Hi,
audible,
yes, you
sir?
are audible. Please go ahead.
Hi.
Yes,
Hi,
yes.
sir. I'm Dr. Mansi, sir. I'm currently working as a senior resident in a government hospital in Sivni, in Madhya Pradesh.
Wonderful. So yes, I was just saying that, this is the right time to be and to understand myopia and to be part of something which gradually is going to progress. So, we can discuss if anybody has any questions with regards to the syllabus, with regards to discussions, with regards to how we can carry forward this. My expectation would be that, when I post the video on YouTube, you can see that video, you can dissect the video. So just for the sake of privacy, what we do is we post the video, we add all your emails so that you can have access to the video. And then after that, we try to post a recording of previous batch. So we have 2-3 batches before this batch. So we try to post video of that batch also, the Zoom meeting which we had with that batch, so that if there are any clarifications or any questions which have already been covered by them, you can go through those recordings also. And if there are any questions, my expectation is that you should post them on WhatsApp. If you feel that you don't want to ask questions in a group, you can DM me, you can send message personally to me, and I will just post a question. So what happens is that if you post a question, it becomes much easier. It will reduce time lag in understanding. I can answer it promptly on the WhatsApp, or I can take it up in the group. If it is a question which concerns everybody, it is better to answer in a group. There is nothing like I don't know this or that. I can search it if I don't know. If it is a clinical question, most of the times I can answer it quickly also. But it will be a good idea if you can post things on WhatsApp. It is much easier to back those answers with references, so that it becomes easier for you also to understand that this is an evidence-based answer and not just my experience. So one expectation is that if possible, you should see the videos in that particular week. It was normally I would be posting videos either in part or full videos, but they are not more than, it will not take more than 1 hour. How would I recommend you to see? You see the video, and then you can see it slowly, see relevant points. If you want to take notes, you can take notes, you can ask questions, you can even stop the timeline, write the time, and ask the question that at 4 minutes 26 seconds you were talking about this particular point, and how it is relevant to the practice. How it will help? It will help mainly because what happens is, the reason why I believe that this medium is better than doing a CME is that the videos are normally repeatable videos. You can see the video a couple of times, you can slow it down, you can see the slides. Whereas in CMEs, what happens is, somebody has said something, you can't go back, you can't question that person why you said this, and whether you actually meant this, or you just said it while recording and you actually don't practice that. So what happens in conferences is that we cannot go back, we cannot ask the person that why this particular thing is relevant, this particular thing is not relevant, why do you think this drug works here? So that is the first thing, which is my expectation. The second expectation is to put questions. The third thing is that there will be around 8 to 9 8 meetings. Most of the meetings we have certain articles which we post in the group, and anybody of you can take up that article to present. Like those articles are something which are not very much available, or they are not really proven, and yet we expect that these things may become a norm in future. And so even if the fact that I am not taking them in the lecture, I want you all to know about it, so that at least you have a broad idea what is going to come up in the future, some of the equipment, some of the molecules, or some of the drugs that we can discuss in the future. So that was from my side. You can tell me what exactly and the way you want it. We can tailor make it, because this medium is better. We can fix a day, and normally I try to take the meetings on this time it was at a short notice. Nitin pointed it out, but normally we try to give a week's notice. So typically it will be on a Monday or Tuesday that we post a video, and then on a Thursday or next week Monday we keep a Zoom meeting. But we can see, because it is a medium which is online, we can change things. That is not a problem. And that is the reason I wanted everybody to know everybody, so that as a collective, as a group, we can have more learning. Dr. Shreyas, Dr. Snehal, Dr. Uday, any suggestions? Dr. Chandrakishore? Yes, ma'am.
No, I mean, only that if you could avoid, I mean, if you could have the meeting on a fixed day, if we know that it is a little bit better for us to adjust. Like if it
We
is,
can make a plan. I mean, I can put up a schedule right now. I mean, in 1 or 2 days, what days will be meeting, but we try to avoid weekends because normally everybody is busy on weekends. We
like a
try to
Monday or like Tuesday, I mean,
holidays.
like with everyone's convenience.
Yeah, yeah. No, so it is not fixed. Normally I will ask what day everybody wants. In some of the groups in the previous batches, I used to keep a poll also. But then I thought that there was too much of, back and
Ambiguity.
forth.
Yeah.
So there will be 50% of the people who will say that Wednesday 6:30, and another people would say Thursday 6:30 or Thursday 7 o'clock, and somebody would be more preferring on a Sunday, but most of others would say कि Sunday तो नहीं रखना है. So then I started taking a more autocratic view that okay, we'll keep on this day, and I am the deciding
Yeah.
authority.
No
There is nothing
problem.
like
Just
that.
no problem. But if we know, then we can arrange.
Yes, pakka, pakka.
Thank you.
If there are any questions, if somebody wants to ask any question, you've gone through the video. If there are any questions pertaining to those videos, or if you want to go back and see the videos, that is fine. Normally, once we post the next video, we remove the privacy settings. But if you want to go back and rewatch the video, you just have to message in the group. We will add your email. Yeah, Tuesday evening is fine, Dr. Chandra. Sure, we can do it on Tuesday evening.
Yes, that
Normally, it
would
will
be
be
good.
either Tuesday or Thursday. Yes, Dr. Snehal, you were saying something.
Tuesday is good. Unmute. Tuesday is good.
Yes. Okay, we'll add your email, Dr. Shreyas. Your email is not added. Okay, please send your email in the
No, sir,
group.
not added.
Okay, just send me your email in the group and we will add it. It is a Gmail, right? Try to send a Gmail because YouTube nowadays
Sir.
tries to take Gmail. Okay.
Thank you, sir.
Okay. Any other questions or anything we want to touch upon? There are few articles which also I have mentioned. There is one article by which talks about emetropia. It's a good article. You can read and we can discuss it. Rest of the articles are mainly on the prevalence of myopia. The theory of emetropization, that one article is good article. There are some counter articles to that which talk something else. So those articles are they are also there. This is the more comprehensive article, so that is the reason I shared that. So
Excuse me, sir.
Yeah.
Which basic instruments we should have in our OPD for myopia control? Autorep you have, but for axial length and everything,
So
which you will
right now for axial length, we are using our optical biometer, which normally we use for cataract surgery also. But as I was saying that, now there are 3-4 biometers which have come up with autoref. So they have started making machines mainly for myopia. So Myopia Master was there since 2 years. That is promoted by Oculus. The problem of Myopia Master is that it is around 34 lakhs. So it is too expensive. The second instrument I think is Maya from Topcon. It is also around 18 to 20 lakhs. Good equipment because it also gives you Placido ring topographer. Then the third equipment is Hewitt's optical biometer. In that they have a good optical biometer and they have incorporated a software for myopia. I don't know whether it does autoref or not, but it is optical biometer with a software to look for myopia progression. And then there is a
Actual topography is also there with that, sir.
there is
With Hewitt's optical biometer.
in Hewitt's also there is a Placido topo.
Yeah, Placido topo.
Yes, there is a topographer. I just read last week. There is a topographer along with that. And it also has, it can give you graphs to talk about myopia progression. And then I think recently they have launched OBM 12 by Remedio people that has got an autorefractor, autokeratometer. Obviously, autokeratometer is there with a biometer, normal biometers also. And that also has ACD, AL upon CR ratio. So that is, they have some 12 parameters that they do. And so they have named it as OBM 12. Optical biometer for myopia 12. So it will measure 12 parameters. Also, it will have a software which will give you the progression curves. So this
Sir, I have one
sir, बताइए.
question. Sir, what is the criteria of the progression of myopia? Means in how much year, how much diopter it, if it increase, we will ask that it is a myopia progression.
So normally, if myopia progresses by more than 0.5 diopter in a year, it is called as progression. Or if the axial length has progressed beyond 0.2 to 0.3 millimeters, then it is known as a progression.
So it has to be more than 0.5 or 0.5 and more than 0.5.
More than 0.5. More than 0.5.
Okay.
It
Okay.
is
And
straightforward.
sir, when we will start low dose atropine, is it any criteria?
So if there is a progression, we will start low dose atropine.
Okay, sir.
So this is the same criteria, Dr. Saab. My point is very simple. If you see a progression more than 0.5 diopter per year, or if you see axial length elongation is more than 0.2 or 0.3 millimeter. Why 0.2 and 0.3? Because we all know that in younger years, the progression is faster. So it can be 0.3 millimeter per year also. And in the gradual years, like if you see a child who is around 13 years, their progression, even if they progress by 0.2 millimeter, that is known as a progression. So there is a difference in age. Although most of the studies would say that 0.2 millimeter or more is definitely a progressor, but some of the studies do understand that there is a physiological elongation, and so in younger age group, 0.2 is normal, not normal, but there will be a slightly quicker progression, and so they take 0.3 millimeter for a younger age group and 0.2 millimeter for an older age group. I think in the chapter 2, rather in the next talk, which is on myopia documentation and progression, we have taken all these points. What is progression? How to document that? Who is a progressor? Who would need a treatment, regardless whether it is a low dose atropine or glasses? But that is in the next chapter.
And do we need
Okay,
to
okay.
measure the
Thank you, sir.
axial length every time, or only the dioptric progression is enough to document progression?
No. You have to measure axial length because the reason is the reason why I always tell to measure not only axial length but also K reading is that, so there are two refractive surfaces, we all know, cornea and lens, and there is only one thing that can be really modified is axial length. So there are three things. There are actually two things to know for a refractive refractive part of eye. One is the K. So you have to measure K and you have to measure axial length, because if there is a progression, then you have to document it why the progression occurred. If there is a change in cornea, which is obviously little rare, and bulk of the progression is because of axial length also, axial length only. So almost 80 to 90 or rather 95% of the patients who progress will progress because of axial length growth. That is understood. But and yet you have to document that. What is the progression? Because that is the only part which is objective. See, we as a collective, as an ophthalmologist, we all know that your 2.5 may be my 2.75. It is very easy because your lane may be 6 meter and my lane may be 5.75 meters. It may be 21 feet, or so there are a lot of variations. Why there are variations? Because you can put your ophthalmic chair unit and you may not measure it you may measure it from the wall to wall, and when the patient is sitting, he will be sitting at least 1 foot ahead of chair unit. There is his head and there are his eyes. So he is then having at 21 feet and some 20 feet, and somebody else is measuring at 19 feet. So the problem is that with refraction, there can always be a small variation. You may be using atropine, I may be using home atropine. So there will be some small changes here and there, but it is very difficult to find changes in
Objective
objective,
measure. Okay, axial.
objective parameters like axial length.
Okay.
Yes.
Sir,
Nirali has. Yes.
hello. May I ask a question? Actually,
Yes.
I don't have an optical biometer, and I would need only ultrasound-based 8 scan. So, will it make difference with in the measurements as such?
I don't think it will make a difference. The only problem with A
Contact.
scan is, or contact kid may not be very cooperative, and inter-test variability between one test and another test may be little bit higher. So you may have to adjust to that.
Okay, so how about if I do immersion in every patient kind of?
But it is difficult in less than 7 years of kids to agree for immersion. But if you do immersion, it is fine, sir. I think by the end of by the end of this course, I think you will be convinced to buy a modern modern optical biometer with autoref.
Yeah. Okay, sir. Oh, thank you, sir.
I think Nirali has joined.
Yeah, hi sir,
Yes.
good evening.
Good evening, madam.
If now I'm seeing quite a few kids who are like 4 or 5 years old, and they come with -5, -6. One of them has not progressed beyond that -5. So,
Good.
so he's a congenital myope and he's not progressing. Like,
True,
so
true,
then
very true.
should we start in such kids or not?
No, there is no. So the whole point is that we have to understand that we have to start the drops to stop the progression. If there is no progression, I try to give analogy of glaucoma. If you see an abnormal disc, we don't start anti-glaucoma measurement. Only if we see progression, only if there is something, we would try to start something to curb that. So here also we have to document the progression. Especially, we have to document that there is an axial elongation, axial progression.
Yeah,
And
that
then we
is
can
what has
start the
not been done. I should get that axial length measured. All of them are not willing.
as much as possible, madam. Because if you don't measure axial length, the problem would be you won't be able to know whether your drop is working or not.
Yes. Now we have got an optical biometer in a hospital, so
Yes.
I can start there.
I
Because I
think
don't have it in the.
as I was telling, gradually these optical biometers will be there with myopia management and all that, because there is a good upside potential. I can understand gradually there will be more and more there will be more and more market for optical biometers with myopia software, because more and more companies like Zeiss, Essilor, they are also trying to promote. Zeiss is also coming up with their, they already have IL Master 500. They are also coming up with a software where they can, add something with IL Master 500 and come up with something to do for myopia progression. Because, I don't have any financial disclosure for that, but they want to promote their own glasses and they already have an old optical biometer. So I think they are also doing something. They can also come up with some device. Already, as I mentioned, there are 4 or 5 companies which are already there in the market trying to promote that.
Okay, yeah.
Okay, then I think we can stop the meeting for today. If there are any questions, please we can do it on the group. Yes, madam, tell me. Okay, she's just. It is muted. Okay, then what I will do is I will